Welcome to today's NDEP webinar, Food Insecurity and its Impact on Diabetes Management, Identifying Interventions that Make a Difference. My name is Michelle Owens-Gary, and I'm a behavioral scientist at the Centers for Disease Control and Prevention, Division of Diabetes Translation in Atlanta. Today, I will serve as your moderator. Food insecurity can negatively affect health outcomes. It can impact diabetes self-management, glucose control, healthcare utilization, and one's ability to cope with a chronic illness. This webinar will focus on defining food insecurity, its association with diabetes, and strategies that diabetes educators, health educators, and community health workers can use to help people with diabetes improve self-care. Today, I'm honored to present a fantastic panel of experts that literally cover the states from coast to coast, each one with plenty of expertise in food insecurity. Our first presenter is Dr. Victoria Mayer, who is an assistant professor in the Department of Population Health Science and Policy and in the Department of Medicine at the Icahn School of Medicine at Mount Sinai. She has a medical degree from New York University and received a Master's of Science in Health Policy Research from the University of Pennsylvania as a General Medicine Fellow. She completed her residency in internal medicine and the Einstein Montefiore program in primary care and social internal medicine. Dr. Mayer's work focuses on improving chronic disease outcomes in vulnerable populations. Dr. Mayer will be followed by Dr. Monideepa Becerra. Dr. Becerra is an assistant professor in the Department of Health Science and Human Ecology and coordinator of the Master of Public Health program at California State University, San Bernardino. Dr. Becerra's research emphasizes social determinants of health among vulnerable populations, with recent publications highlighting the role of food insecurity on health and behavioral outcomes. She was a U.S. Department of Veterans Affairs National Diversity Fellow in Wisconsin and is an elected board member for the National South Asian Public Health Association. And our third and final presenter is Dr. Gary Ferguson, who recently joined the Rural Alaska Community Action Program as its Chief Executive Officer. During the past 15 years, Dr. Ferguson has served the Alaska Tribal Health System, most recently at the Alaska Native Tribal Health Consortium. He is the co-creator of the Store Outside Your Door initiative, addressing food and nutrition security for the First People of Alaska, and serves on the American Diabetes Association American Indian Alaska Native Advocacy Committee and as commissioner for the Municipality of Anchorage Health and Human Services Commission. He is also a member of the National Diabetes Education Program's American Indian Alaska Native Stakeholder Group. We welcome you all to our webinar today. So without any further ado, we'd like to invite Tori to the mic to present. Thank you, Tori.
Good afternoon. Thank you to the NDEP for having me here today and to all of you for joining. I'm happy to be speaking with you today about definitions of food insecurity, measurement of food insecurity, and interventions in response to food insecurity in the United States. I'm going to start by sharing some common definitions of food security, food insecurity, and hunger. The United States Department of Agriculture defines food security as access at all times to enough food for an active and healthy life. Food insecurity, on the other hand, is the household-level economic and social condition of limited ability to acquire adequate food. Another commonly used definition of food insecurity is whenever the availability of nutritionally adequate and safe foods or the ability to acquire acceptable food in socially acceptable ways is limited or uncertain. Food insecurity is different from hunger. Hunger may result from food insecurity, but it is an individual-level physiological condition, which may be defined as a sensation caused by involuntary lack of food. In the U.S., the United States Department of Agriculture, or the USDA, has been publishing information about food insecurity annually since 1995. The estimates of food insecurity come from a survey that is funded by the Economic Research Service and conducted by the U.S. Census Bureau. Each year, they select a representative sample of the U.S. population and ask them to complete a survey. The survey was developed and extensively tested by experts from academia, government, and the private sector. This next slide shows the questions that make up the Household Food Security Survey. It's an 18-item survey, but it contains skip patterns. So if a participant answers no to the first few questions, he or she does not complete the entire survey. And questions 11 through 18 are asked only if there are children under 18 years old who live in the household. According to the responses, participant is characterized as food secure, meaning they report no food insecure conditions or only one or two food insecure conditions, or food insecure, meaning they report 3 or more food insecure conditions. Food insecurity is then further classified as low food security or very low food security. And very low food security means that one or more members of the household reduced their food intake and eating patterns were disrupted because of insufficient money and other resources for food. This figure shows the results of the USDA survey for 2015. 12.7% of households in the U.S. experienced food insecurity at some point during the year, and 7% experienced food insecurity in the previous month. 5% of households in the U.S. experienced very low food security during the year, and 2.9% during the previous month. So how do these results compare to other years in the U.S.? This figure shows the USDA's findings for food insecurity and very low food security from the years 1995 to 2015. The 2015 estimates did drop from 2014, and this drop was statistically significant. This chart shows the percentage of households reporting different indicators of food insecurity in 2015 by food security status. So if we look at the first indicator, worried that food would run out, almost all food insecure respondents worried that their food would run out, and some food secure respondents worried that food would run out. Looking at another indicator, almost 40% of those with low food security and 96% of those with very low food security reported that they cut the size of meals or skipped meals because there was not enough money for food. And finally, I want to point out that in 31% of households with very low food security, an adult did not eat for a whole day because there was not enough money for food. This next figure shows how food insecurity rates vary in different socio-demographic groups. Food insecurity rates are higher than the national average among households with children, among households with children headed by a single woman or a single man, among women and men living alone, among households headed by individuals who identified as non-Hispanic Black or Hispanic, and among households living below 185% of the federal poverty level. Okay, this next slide shows a map that's available from the Feeding America website and shows levels of food insecurity in the U.S. at the county level. And you can see that different areas of the country have varying levels of food insecurity. And this interactive map allows you to learn more about food insecurity in your county or state. You can also learn on this website about the average meal cost in the county and program eligibility among individuals who are food insecure by county, state, and across the entire U.S. So far, I've been talking about defining and measuring food insecurity using survey tools and statistics. Now I'd like to let you know that there are a number of projects, groups, and organizations that can help everyone learn about food insecurity and hunger from the perspective of those who experience it. One of those projects is called Witnesses to Hunger, which is a research and advocacy project that involves mothers and caregivers of young children who have experienced hunger and poverty, sharing their photographs and stories. You can visit the website below to learn more about this work. I also want to mention the 2012 documentary, A Place at the Table, which is a documentary on hunger in the United States. The website for this documentary has resources for community screening, social media tools, and hunger resources and fact sheets. Next, I'm going to speak about some of the responses to hunger and food insecurity in the U.S. We'll start with federal food and nutrition assistance programs. The Supplemental Nutrition Assistance Program, or SNAP, is the largest of these programs. SNAP was formerly known as the Food Stamp Program, provides eligible families with funds to purchase food, and aims to alleviate hunger and improve the nutrition and health of low-income people. Most households with an income that is less than 130% of the federal poverty level are eligible. In 2015, nearly two-thirds of SNAP participants were children, elderly, or had disabilities. 44% of SNAP participants lived in households with earnings, meaning members of the household had jobs, and the average household income of SNAP participants was 59% of the federal poverty level. The Special Supplemental Nutrition Program for Women, Infants, and Children, or WIC, is another large federal nutrition assistance program. This program consists of federal grants to states for supplemental food, referrals, and nutrition education for low-income pregnant, breastfeeding, and non-breastfeeding postpartum women and infants and children up to the age of 5. Most states also include farmers market vouchers in their WIC programs, and households are eligible that have an income below 185% of the federal poverty level. This slide shows the breakdown of WIC participants in 2014, and you can see that more than half of the participants were children aged between 1 and 4. Other federal programs that are responses to food insecurity include School Meals Program, the Summer Food Service Program, the Child and Adult Care Food Program, and food distribution through commodity programs. Other responses to food insecurity include community-based food and nutrition assistance, which include emergency food providers such as food pantries, food banks, and soup kitchens. These providers are commonly private charitable providers, but some providers are supplemented by the USDA through the Emergency Food Assistance Program. If you'd like to learn more about the nutritional information, guidelines, and regulations for these various programs, you can visit the websites on this slide. Some newer innovative responses to food insecurity include incentives for SNAP participants to purchase healthy items like fruits and vegetables and food prescription programs, where health systems prescribe healthy foods through coupons to farmers markets, farm share programs, or grocery stores. My own institution is currently piloting a food prescription program partnered with a farm share program. And now it's time for our poll question. I'd like to take a moment to ask you all to participate in this poll. Please select what you think is the correct completion of the statement. Food insecurity in individuals with diabetes has been associated with A, hyperglycemia, B, hypoglycemia, C, both hyperglycemia and hypoglycemic episodes, and D, none, meaning neither hyperglycemia nor hypoglycemic episodes. Okay, and it looks like the most popular answer is C, which is both, which is in fact the correct answer, and we'll be talking about that in just a second. So I'm going to talk a little bit about the evidence about how food insecurity affects a person's diet. Many research studies have examined the relationship between how much foods cost and food and diet quality. These studies show that in general, energy-dense foods like refined grains, foods with added sugars and fats are cheaper than healthier, nutrient-dense foods like vegetables, and that lower quality diets are in general less expensive. Other researchers have found that food insecurity is associated with lower quality diets, lower produce intake, and fewer healthy eating habits. These findings may help explain how food insecurity is associated with health. Food insecurity, as many of you already know from the poll slide, several research studies have shown that food insecurity is associated with diabetes. In addition, there is a growing body of research that has found that people with diabetes who are also food insecure are at higher risk of poor glucose control and hyperglycemia, as well as at risk for hypoglycemic episodes, which can result when individuals who are taking glucose-lowering medications have periods of time when they do not have enough food. The next response that I'd like to discuss with you is screening for food insecurity in health systems. The American Academy of Pediatrics now recommends screening for food insecurity, and the American Diabetes Association recommends assessing for food insecurity and other important social determinants of health. At many health systems across the country, there's an increased focus on population health and on addressing social determinants like food insecurity as a way to improve outcomes and reduce costs. Multiple health institutions across the country are instituting various screening measures. I'm sharing with you here a further description of the American Academy of Pediatrics recommendations from 2015 on food insecurity. So the AAP recommends utilizing a two-question screening tool, which the next slide will show you. They recommend that pediatricians familiarize themselves with referral mechanisms, that they familiarize themselves with the nutritional content of food offered in supplemental food programs, and familiarize themselves with associated vulnerabilities and risks with food insecure households, that they educate medical students and residents, they advocate to promote access and funding of programs such as WIC and SNAP, and that they support research to optimize access to high-quality, nutritious food. This is the 2-item screen recommended by the American Academy of Pediatrics. And you may recognize these two questions as they are from the 18-item USDA survey that I mentioned earlier. The two statements are, within the past 12 months, I worried whether my food would run out before I got money to buy more. And the second item is, within the past 12 months, the food I bought just didn't last and I didn't have money to get more. And a positive answer showed a sensitivity of 97% and a specificity of 83% compared to the 18-item USDA survey in the Hager study mentioned on the previous slide. These items, or these quotations, are from the ADA Standards of Medical Care for Diabetes from 2017 in the section Tailoring Treatment to Reduce Disparities. The ADA states that providers should assess social context, including potential food insecurity, housing stability, and financial barriers, and apply that information to treatment decisions. Patients should be referred to local community resources when available. Providers should recognize that food insecurity complicates diabetes management and seek local resources that can help patients and the parents of patients with diabetes to more regularly obtain nutritious food, and that providers should consider risks of hypoglycemia in medication decisions. These next two slides provide information on hunger resources throughout the country. This first resource is from the USDA, who maintains a hotline and a website with information on emergency food resources. This information is about another nationwide organization that provides information on hunger resources by phone, text, and online. Thank you so much for your time today, and I will turn it over to our next speaker.
Thank you very much. My name is Monideepa Becerra from Cal State San Bernardino, and I'm very honored to be invited by NDEP to join the group to talk about food insecurity. And specifically, I'm talking about how food insecurity is related to health outcomes, with, of course, focus on type 2 diabetes and how that's managed. So one of the first things that I want to discuss is how food insecurity is related to chronic illnesses. And it may seem a very complex thing, but I want to break this down because the rest of the slides really talk about how these factors are related to each other. So food insecurity, as our previous speaker has already explained the definition, can actually lead to stress. This is often because, as you may recall from the questionnaire, food insecurity is measured through have you reduced the portion of your meal size? Have you skipped meals? Is it because of lack of money or not being able to afford healthy food? All of these shortages can lead to stress. But when this stress becomes chronic, as in long-term, it has been shown in the literature to lead to obesity. And in a few slides, we'll talk about how that is the case. When you have obesity, as you've all heard several times, it is a precursor to many other chronic illnesses, such as type 2 diabetes, heart disease, even several cancers. And these chronic illnesses, the more a person has, the more financial hardship they're likely to have due to the need to manage personal needs such as food as well as the healthcare costs, whether it's paying for copays or visiting the emergency department or visiting a physician. All of this can lead to more poverty due to increased healthcare costs. Again, that leads to food insecurity. But it's not just that simple, because we know when we're talking about food insecurity, not eating enough food can lower your immune system. Lowering immune system can lead to chronic diseases as well as obesity. If someone is obese, they're likely to have stress due to poor body image perception. And that stress, again, can lead into financial hardship, because those who have stress are likely to have mental illness. Mental illness then leads to less work hours. And again, that leads to poverty. So it becomes this cycle. But why is it that I'm talking about chronic disease particularly? While food insecurity in the literature has been related to some other outcomes, chronic disease is our biggest burden in the United States as well as the world itself. For example, just for the purpose of definition, chronic diseases are persistent because they last for 3 months or more, and that's the best way to define it. There is no way to prevent it through a vaccination. There is no cure with a medication, and they do not disappear. It is estimated that 88% of Americans who are 65 years or older have at least one chronic disease, with 1 in 4 having more than one chronic disease. So that's a large percent of Americans. The world population as well as the United States population is getting older. So this is becoming a huge burden for our healthcare system and our public health system as well. One of the biggest things that's attributed to chronic diseases is dietary behavior. Of course, smoking, physical activity, and other things are as well, but we often hear diet as a precursor, poor diet, to having obesity and other chronic illnesses. So food insecurity, as our previous speaker has already mentioned, could potentially be related to diet. And before we jump into that, I want to go ahead and have a chance to have a little check right here. So the question, the knowledge check, the question says food insecurity is related to which of the following? Increased mental illness, decreased BMI, so that's decreased body mass index, increased healthy dietary behavior, or none of the above. Okay, so thank you. Looks like majority of participants here, we mentioned that increased mental illness. Let's go ahead and see what we find out. But it looks like we're all in the same direction. And we'll go through the next slides and see if we can really answer this question correctly and why I bring up mental illness when really I'm focusing on chronic illnesses, or specifically type 2 diabetes. So as I mentioned earlier, our speaker already mentioned diet here, so I just want to go a little bit in details. What the literature has shown really, and I've listed the resources for you, is that those who are food insecure, and I'm talking specifically about adults, American adults here, are less likely to eat the recommended amount of vegetables per day. That's the 5 servings. They're also less likely to have fat avoidance behavior. What that means is cooking with items that are high in fat. Those who are food insecure tend to do so. Going out to eat, if you're food insecure, are more likely to eat food that's high in fat. If you're food secure, on the other hand, you're likely to cook with healthier items, likely to eat healthy when you go out. The other major thing that has come out of diet and food security is that among veterans. We have a huge population of U.S. veterans due to the Operation Iraqi Freedom who have returned to the U.S. They are generally a younger population. And what has happened among them, we've noticed in the literature, high rates of type 2 diabetes very early on, high rates of obesity very early on. And there's only been a couple of studies who've actually looked into diet among veterans. And the numbers are there for you. I'm not going to read the numbers, but if you notice, it basically is saying veterans who are food insecure are more likely to eat fast food and soda. Especially the soda intake goes up by 142% if you're food insecure. On the other hand, food intake goes down by 24% if you're a food insecure veteran. Again, I bring up the U.S. veteran concern because this is a growing problem. Whenever we think about U.S. veterans, we think about mental illness and nothing really beyond. But food insecurity is becoming a larger problem with the veterans because they're a younger population that's returning to the United States. So diet, as we noticed, is strongly related to food insecurity itself. And of course, as we've heard several times in the past, poor diet can lead to obesity. And what the literature has shown is when you look at 12 different states across the United States, that's well over 66,000 people. If you have food insecure, you're 32% more likely to be obese. In a study that included 810 pregnant women, Again, food insecurity was related to being severely obese before pregnancy, as well as increased weight gain during pregnancy. The problem with these two studies is predominantly they were focused on a smaller population or just one point in time with the 12-state study. But longitudinal study, this is when the population was followed over a period of time, they noticed more food insecure a population was, more likely their body mass index was higher. So more food insecurity, higher BMI. Again, higher BMI is the indication of obesity and long-term chronic illnesses. So what else has to do with diet and obesity? While we know obesity is related to food insecurity, it's really not just diet. That's often the focus is always on diet. Obesity and stress are strongly related, and this is where the hard sciences, the biological sciences, have shown some of this evidence. What we notice is populations who have shortage in food tend to have stress, and this stress, when it becomes long-term, becomes chronic. Chronic stress, this is 3 months or longer, can lead to biological changes in the body, where there's abdominal fat accumulation, visceral fat accumulation, cortisol release, and all of that leads to metabolic syndrome and obesity. And as we said before, obesity is then related to actual chronic diseases. So what chronic diseases has obesity shown? NHANES, which is a large-scale national study, have shown that those who are food insecure tend to have hypertension, hyperlipidemia, this is high cholesterol, as well as lab-confirmed diabetes. This is a patient reporting that there is diabetes, but as well as showing labs and exams showing that there is actual type 2 diabetes among these patients. The same study also showed that depending on the level of food security it is, the chronic kidney disease rate goes up. So if your high food insecurity rate, the rate of chronic kidney disease is 20.3%, compared to somebody who reported no food insecurity, that's a lot lower at 15.7%. Even among children, we notice that if a child is living in a food insecure household, they're 2 times more likely to report poor or fair health compared to excellent or good. Similarly, if a child is living in a food insecure household, they're 1.4 times more likely to report asthma. And here's the interesting part. Why asthma? Because asthma is usually not related to food insecurity. And this is because if you think about what food insecurity does, it lowers the ability to eat healthy meal on a regular basis, which impacts your immune system, and that negatively impacts your respiratory illness. So in this case, asthma. So this is why more and more we're noticing that food insecure households, especially among children, are having higher rates of asthma as well. And asthma and mental health are strongly related, which is why I bring up the issue of mental illness. There were 2 studies that were done in California, one among Hispanic population and one among African Americans, that looked at serious psychological distress. Serious psychological distress is a validated instrument that's used by Kessler. Kessler is a researcher at Harvard that measures the likelihood somebody could get serious mental illness in the long term. And you look at the graph, blue is for Hispanic, red is for African Americans. So among Hispanics, if you're food secure, the prevalence of this serious psychological distress is 2.67%. But as you become food insecure with hunger, and our previous speaker already mentioned the issue of hunger, the rate of serious psychological distress goes up to 13.4%. We see a very similar trend, but higher among African Americans in California. African Americans who are food secure reported 5.28% of serious psychological distress. But when that becomes food insecure and hunger, that population reports nearly 23% of serious psychological distress. So food insecurity and mental illness are strongly related. Now, while both these studies are, again, only in California and they're cross-sectional, as in it was done at one point in time, they show a strong indication of what could happen at a larger scale and what future researchers could potentially look at. So we talked about mental illness, a little bit about diabetes, and a little bit about asthma, but what is really out there when it comes to food insecurity and diabetes? So a study was done recently looking at a systematic review. So this is when they take all the studies published in North America and try to find a cumulative summary of what the studies have shown. And they noticed the higher the rate of food insecurity, the higher the rate of diabetes. So diabetes rate among those who were food insecure in the United States was 10.2%. but when you compare to those who were food secure, was 7.4%. And it's not just those who were food insecure. The researchers then broke that down into different levels of food insecure. So mild food insecurity or severe food insecurity. When looking at the diabetes rate among mild food insecurity, it was 10%. When you look at diabetes rate among severe food insecurity, it went up to 16.1%. So again, a much larger percent of those who were food insecure, severely food insecure, had type 2 diabetes rate. There were several other studies, and I will only mention a few of them, have shown similar trends. In a longitudinal study, again, this is when the population is followed over time, they've shown that if a population is food insecure, they're 50% more likely to have type 2 diabetes. The patients who are food insecure are also have a higher rate of type 2 diabetes, even after accounting for everything else. For example, lifestyle factors, so smoking, drinking, physical activity, income level, employment. Even after accounting for all of that, if you're food insecure, 2 to 3 times more likely to have type 2 diabetes. And similar trend was also shown with food insecurity and gestational diabetes. And we know gestational diabetes could potentially lead to type 2 diabetes in the long term. One of the major things that we also noticed is looking at the healthcare burden of food insecure individuals. This is not just about what happens to their health outcomes, but also are they spending more money because of worse health outcomes. National Health Interview Survey, which is a large-scale national study, it is not limited by the issue we have with small data is where we cannot generalize to the population. Because they use census information to make these data weighted to represent the entire United States, we can draw larger conclusions for the U.S. population. And in one of the studies, they showed a dose-dependent relationship, which means the higher the food insecurity level, the less diabetics were to use medication. And this was even higher among racial ethnic minorities as well as those who had more than one chronic disease. A similar study using the same database also found that 1 in 6 patients who were diabetes were also food insecure. And if they were food insecure, they were less likely to use medication. They were reducing their medication, they were delaying it or avoiding it because it's financially hard to afford medication. A smaller study, however, found that diabetic patients who were going to food banks, kitchens, or soup kitchens were actually 1/3 of them were paying for medication versus food. This slide really talks about in California Health Interview Survey, which is the largest state health survey, looking at the emergency department utilization among diabetics. And diabetics who were food secure, they reported a rate of ED utilization at about 7%. But food insecure diabetics actually visited the emergency department a lot higher, nearly at 13%, showing a much higher rate of healthcare utilization. This high rate of healthcare utilization means higher copay, higher medical bill, which means we're going back to the same situation where patients are having to choose between food versus healthcare, what they need to maintain their health services. Now, every study I've talked about has their own limitations and strengths. Most of the ones we talked about were cross-sectional, so we cannot say food insecurity causes diabetes or causes obesity because the cross-sectional study, the 1-point-in-time study, does give, however, a strong indication. One of the problems in the literature is that the food insecurity measure is inconsistent. While a previous speaker showed what it should be done, a lot of studies don't necessarily use all of that. So we need that more stronger in the literature where people are using the USDA 12-item scale to assess food insecurity. Regardless of these limitations, however, consistently this research shows that if you're food insecure, you're more likely to have higher healthcare burden, be it negative diseases such as chronic illnesses or higher healthcare cost itself, both among adults as well as children. And a previous researcher already mentioned SNAP, and the research does in fact show that SNAP reduces the burden of food insecurity. However, this is not true for all populations. A study in California, which has one of the largest Hispanic populations, showed that Hispanics, even when eligible, are less likely to participate in SNAP. And that is often because of lack of knowledge, stigma, the healthcare cost, which limits the ability to want to apply to SNAP, as well as transportation. And this is where Promotora model or Promotores, which are community health workers, can come in very handy. It has been shown to be useful in small scale at Mexico-Texas border as well in small parts of California, where community-based resources that are promoted by community health workers or promotores can reach that population that's stigmatized by participating in SNAP. This has also shown some potential with the veteran population, but hasn't been pilot tested at a large scale, where community health workers can reach the veteran population and marginalized population to make sure they're registering for SNAP, or even if they're reducing the stigma and addressing transportation. And before I give it to my next speaker, our campus right now at California State University San Bernardino, we're doing a very similar strategy because we have a 70% high first-generation college student, and food insecurity is extremely high in our population. And what we found is there's a significant stigma with SNAP. So a peer-to-peer education program is actually showing success, and we're hoping a similar strategy can be used more large-scale with the Latino population as well as the veteran population. Having said that, I will go ahead and lead on to our next speaker. Thank you.
Good afternoon. This is Gary Ferguson, and I'm really happy to speak today in our Unangam Tenu or Aleut language, a song, Kanguk, Dr. Gary Ferguson, Akuk. I am really honored to speak today and share about bright spots in addressing nutrition insecurity among our indigenous population, our First People. And just a little bit about myself. I'm from the Aleutian region, the Shimigan Islands, and the community of Sandpoint, and had the privilege and honor of growing up close to the beach and close to a very vital food system. So I grew up hunting and fishing and gathering food, and feel really deeply grateful to my grandparents and my family for showing me how to collect plants and live off the land. And it's been a lifelong pursuit to help keep our next generations connected to our land and our resources and preserving those resources for future generations. I'm going to start with just a little bit about our Alaska Native people and some of the research that's been done looking at diet and food security. And one of the dentists, Dr. Weston Price, traveled in the 30s to our Alaska Native villages, primarily in the Yukon-Kuskokwim Delta, where he noted that our people are examples of physical excellence and dental perfection that has seldom been excelled by any race in the past or present. He talked about our strong, rugged babies. And he also noted some very interesting things, that those who ate from the store, so we had a lot of colonization, we had the fur trade, we had a lot of resources that were being extracted, and so folks came into the YK Delta for a variety of reasons. And so they set up a ship store where folks could buy out of the store and buy flour and processed foods. And what he noticed was the first generation of children born after the adoption of this Western food had some very interesting things happening in their mouth. They had dental arch deformities, they had crooked teeth, and they had a changed facial form in addition to dental caries. And he noted we have few problems more urgent or more challenging than reversing these trends. And we had a really wonderful opportunity to work with 6 Yukon-Kuskokwim Delta communities, and in collaboration with the Yukon-Kuskokwim Health Corporation and the tribes, and Desiree, now Jackson, Tim Gilbert, and Jennifer Johnson was one of the early folks who helped get this project started. Shout outs to them. But we looked at looking at obesity, and we looked at the changing diet in the YK Delta, which was really compelling when we looked at majority of women, and it was primarily women in this study because the study was on the folks who actually provided the food to the homes. And majority fell below the recommendations for fiber, vitamin D, vitamin E, calcium. And when we were looking at store-bought foods, sweetened beverages and pop were the main contributors to energy, carbohydrate, and sugar intake. And what was really interesting in the study was traditional foods, even though they were a small part of the diet, provided a huge amount of the nutrition, 34% of protein, 27% of iron, good chunk of vitamin A for thinking about immune system and ability to be vital and healthy, zinc, and it was low in carbohydrates and in a small percentage of the overall calories for energy. I'm going to move to a poll, and the poll is currently what percentage of Alaska's food is imported, because this is going to be important in the rest of the presentation as we look at food security. And it's very interesting. I'm going to compare it to in the 50s, so things have dramatically changed. The biggest vote was 70%, and you're close. Actually, 95% of our food is currently imported from outside, which makes us very vulnerable in times of disasters. And we've had periods of time when there's been things going on in the lower 48, earthquake or natural disaster, where our food system has been severely disrupted, and many of our cities are only able to have a 2-week food supply, if that. So definitely the importance of having a connection to how to hunt, fish, gather, and grow your own food, and the ability to have more of a local food system and a more vibrant food system, which I'll talk more about. I've been involved with the Alaska Food Policy Council and some of our work to make sure we grow our own local food system. But I first want to talk a little bit more about the changes in our Alaska Native diets. And when we look at the shift to Western food, and which often increases our food insecurity when you're just going to the local store and counting on them to have the food that you need, which is often more processed in our villages and in our rural communities. And what's been done, a recent study looking at the decline in vitamin D levels since the 60s to present with our Alaska Native women. This is a study that Alaska Native Medical Center colleagues and the CDC Arctic Investigation and our Yukon-Kuskokwim Health Corporation colleagues conducted, and they found that there was a direct correlation between a decreased marine food intake, or traditional foods, and vitamin D levels. And there's been more research that now has looked at dental caries in pregnant women and their children. So children born from mothers who have lower vitamin D levels tend to have higher prevalence of dental caries, and a host of other risk factors. So when you look at the shift to a more Western diet, and with it often food insecurity, you see a host of chronic disease trends. And diabetes is among them, of course, and that's already been elaborated on by our former speakers about the connection between diabetes and food insecurity, and also shifts in diet. When you look at a changing diet from a more traditional diet to a more Western diet, you see trends. And we know that stress, and that was a big component. I just want to highlight that it isn't just always about the food, it's also about the stress. And in the Native community, there's a big push to understand and help alleviate the trauma that's connected with historical trauma, and helping people to address intergenerational trauma, which is connected also to chronic disease, including diabetes. But our diets have shifted, and some of the research has looked at some of our genetic variants that actually show that if we eat a traditional diet, we don't suffer, and in this case, the congenital sucrase isomaltase deficiency, which this is an article from our Canadian Inuit, which are our relatives from the northernmost part of our state as well, our Inupiaq population, our Inuit population, and the fact that upwards to 10% of that population have this genetic variant where we don't tolerate sugar or grains or carbohydrates, refined carbohydrates well. And so if you eat a more traditional diet, you actually don't suffer from this disease like you would as an infant, failure to thrive, a host of issues connected to disease. If you eat sugar, there is an enzyme you can take, but it doesn't fully address the root cause, which is you're hardwired for a traditional diet versus the Western diet. And the CPT1A Arctic variant also is one that is connected, and we're doing more research looking at its connection to health of our Alaska Native people. This is a fatty acid oxidation process, genetic variant that is a wild type, so it's very common in our population, especially our Yupik and Inupiaq population. And the fact that connections to diet and early childhood nutrition, there's more research looking at that, but this is definitely, again, pointing to the fact that our changing diets based upon our traditional diet and the impact of Western diets are greatly affecting our people. With traditional diets, we have the knowledge that when you eat a traditional diet, you have less prevalence of impaired glucose tolerance, prediabetes, and diabetes. In this case, this is a study in Norton Sound region that called the Gokaden study, that looked at seal oil and salmon consumption and its effect on diet, whereas if you ate a traditional diet that had salmon and seal oil, that you had less prediabetes and diabetes and cardiovascular disease as well. And looking at the roots of our medicine, Hippocrates, considered the father of Western medicine, said some really important things that I think we need to remember as we think of treating our next generation and reducing our prevalence of chronic disease. And, let food be your medicine, let your medicine be your food. And when we look at Maslow's hierarchy, and this is where Maslow actually studied with the Blackfoot Nation to get some of his studies and thoughts, and the Blackfoot Nation takes it to a whole nother level where, when you think of food and addressing some of the basic needs of our people, that it's not just about self-actualization, but it's about the cultural perpetuity. It's the impact on the future of your society. Your culture is definitely connected to the roots around food and food system, and preserving your local food, your traditional foods, the way that you've hunted, fished, gathered your food helps your culture for generations. And that's a really important part as we look at some of the issues in Alaska. Of course, we have the Alaska Federation of Natives Convention each year where we talk about policy and bring all of our tribal leaders together. And there's been a huge push around subsistence and having rights to our own food and self-governance so that we can preserve our local food systems and make sure that there's a balance with resource development and making sure that our foods are available for our next generation. And it's all part of our self-determination. And when we think of the impact of the foods that we eat on our next generation, there's a lot that shows that the foods that our infants eat, and in fact maybe what mom eats during pregnancy, will greatly influence your food preferences for life. And I think it's a really important part. What we eat, and our elders have told us for generations, that what you eat greatly influences the next generation and their food preferences. And we can all think of our comfort foods, right? So, of course, all food can be good food, but if mom eats a bunch of food that is Western, then we're trying to reintegrate traditional foods. Well, you might not crave them if they're not your first foods, and of course, breastfeeding being a big part of your first foods, right? And that's been a big push in Alaska, is to look at, what can we do to address traditional foods. And in this case, just a quick story, I was in Barrow for the Lukatuk, and Patty was feeding her boy Connor. Here it was going on a year old, and mikiak, which is a fermented whale product, very high in omega-3 fatty acids and iron. So addressing some of the issues with nutrition and also giving her boy a taste for traditional foods. And I followed her over the last several years, and her boys are growing up very healthy. Traditional food's been a big push in Alaska Native Tribal Health Consortium, and the work that I used to work with them, and of course colleagues, we're doing some great work around traditional foods, and not just for cancer survivors, but now for all Alaska Native people, how to understand the nutrition value of these foods and the fact that they're often more nutrient dense than foods that we would import. And here's one of our traditional foods, fireweed, which grows across our lands and, of course, across our country, and gathering the roots in the spring. Very rich, we call them wild asparagus, lightly steamed, they taste like asparagus, and they're incredibly nutrient dense. And think back to the Yukon-Kuskokwim study where the vitamin A was low. 1 cup of these greens more than meet your needs for the day in vitamin A, and of course vitamin C and fiber. And when we look at traditional foods, here's a comparison of 1 serving of seal as far as iron content is equal to 2 servings of caribou or reindeer. It'll take you 6 hamburgers to equate to that 1 serving of seal for iron, and 56 hot dogs to equate to that 1 serving of seal. So, our traditional foods are incredibly nutrient dense, and preserving our knowledge of how to hunt, fish, gather, and grow our own food, as well as making sure that these foods remain safe in the environment, are a big priority in Alaska. Our berries, of course, very rich and nutrient dense, and compared to the cultivated blueberries in the lower 48, this is the ORAC value, so antioxidant value. When we look at our wild blueberries, you're talking about 3 to 4 times as high. Dwarf blueberries, high bush cranberries, lingonberries. So very nutrient dense and high in antioxidants, and the importance of teaching people and encouraging people to be connected to their food system is really vital and important. And there's a lot of really great resources. This is just one of the many resources, and/or Jones in the book, The Plants That We Eat. A beautiful portrayal of traditions, including how to ferment greens, which is another really important part as we look at the microbiome and the health of our people as well. And here we are with Elder Delia Stone and Point Hope collecting quagok, or the sourdock greens, in the early summer. Delicious greens, very nutrient dense, again high in vitamin A, vitamin C, and trace minerals. Very rich source of nutrition and vital part of the landscape. And I like to talk about decolonizing healthcare, where we look at food and food as medicine. Is a really important concept for our traditional peoples, and it's such a rich way that we're decolonizing our healthcare and our food systems. And there's a lot that has been highlighted already, and I just want to draw our attention to CDC's work that has already been highlighted around traditional foods across America and in our Native communities. There's some amazing resources that have been highlighting some of these best practices in local food systems and traditional foods. And one of them, the Store Outside Your Door, which I've been a part of since 2006, which is this is our YouTube channel, where you can watch a very short video on how to hunt, fish, gather, and grow your own food, and we connect it to culture and language and elders and youth. There's a lot of components that we look at sharing this knowledge with our next generation and preserving this knowledge. And since then, some of the elders we've worked with have already passed, so we're feeling very blessed to have captured the wisdom that they share with us. And also part of the CDC Native Diabetes Wellness Program. There's many programs across the nation that have been highlighted that you can go online and learn more about these programs, too, in Alaska, Aleutian Pribilof Islands, and Southeast Alaska Regional Health Consortium. And just drawing attention to APIA, this is my home region, and I got to work with Sue Unger and the elders and all of the folks at Aleutian Pribilof Islands Association to help with this book that was a huge labor of love, Kakameaguk, which is our traditional foods and recipes from our islands, and an incredible resource for our people, and also to share with other regions our traditions and things that we can do to keep our next generation connected to our local food system and knowing how to live off the land. And we're so fortunate to have a vital food system in Alaska that we can grow our knowledge about. And a shout out to other programs, Food is Our Medicine, Seneca Nation, amazing programs, amazing resources that they're developing. And these are some best practices across Indian country that there's a lot going on, and these are amazing programs that are growing people's connection to their local food system and preventing chronic disease through nutrition. The Tohono O'odham and the Native Foodways magazine, a great resource highlighting traditional local food systems, cultural ways and practices, preserving this knowledge, and that's a resource that you can sign up for and get that magazine, and there's online resources as well. And I want to do a shout out to Valerie Segrest and Muckleshoot Nation and the work they're doing and spreading traditional food through schools, training for cooks who provide food to their tribal members. Had the honor of working with Northwest Indian College, and we had Elise Crone, Elizabeth Campbell, and others with the Northwest Indian College, and Valerie Segrest. Amazing work that they've done over the years of preserving knowledge around Northwest coastal tribes and the ability to understand the traditional and local foods and how to be more connected to your local food system. And one more highlight that I would really encourage everyone to attend who can, as well as there's online resources. This is the Seeds of Native Health. This is an amazing program that started last year. It's going to be an annual conference, at least for the next while. The group there, that Shakopee Nation, and the work that they're doing is amazing to look at ways that we're integrating traditional foods, both from a research perspective, from an educational institution perspective, and our tribal colleges, and it's an amazing resource. Want to do a great shout out to them, and really about eliminating our food deserts across the nation. In closing, a couple of just comments about overweight or obese. We've got issues in our nation, of course, have already been highlighted, the fact that we've got things related to food insecurity and stress, historical trauma. Type 2 diabetes is a big deal in our nations, and when we look at poverty and the connection to poverty, it's directly connected. And we know the social and economic determinants of health are an area that we need to continue to work on in collaboration with our tribes. A couple of quotes to finish my presentation. The doctor of the future will give no medicine, but will interest his patient in the care of the human frame and diet and the cause and prevention of disease. a very wise man and a very wise quote. And our traditional foods are amazing. This is a salad we made out in Akitan in the Aleutians. We've got a base of romaine lettuce that came from the store, but the rest of it is all, there's some carrots in there, but the rest is all locally harvested greens and flowers that are edible and berries. So there's a lot we can do to celebrate our local food system and help our next generation be connected to our local food system. And I'll close with a quote. We are free to be who we are, to create our own life out of our past and out of the present. We are our ancestors. When we heal ourselves, we also heal our ancestors, our grandmothers, our grandfathers, and our children. When we heal ourselves, we heal Mother Earth. And this is a quote from Dr. Rita Blumenstein, who is one of my mentors and one of our esteemed elders, traditional healers, who is a part of reminding us of the importance of our foods, our traditional medicines, and keeping those alive. And the fact that that's going to be the future part of our healing, that in order to heal our next generation, which we've got issues related to epigenetics and a host of other issues in the ways that we're going to protect our next generation from chronic disease. But she talks about it starts with us. We heal ourselves and we heal our next generations. So I am going to close there, and thank you so much. I'm honored to present, and thanks to our NDEP colleagues for inviting me to present.
Thank you, Gary, and thank you to Tori and Moni as well for all of your wonderful, very informative presentations. So we have several questions that you all posted during the presentation. So we'll go ahead and look at some of those questions and have the presenters respond. Can you provide more information on the food prescription program? What qualifies a patient for a food prescription? Is it a diagnosis or is it their income?
So in the program that we are piloting right now at our health institution, our eligibility criteria include people with diabetes and children who are overweight or obese, and either struggle with food insecurity or are receiving SNAP or WIC. However, this study is currently in the piloting stage and the feasibility stage, but as we move ahead in our work, I look forward to disseminating our findings. And I know that institutions at other locations around the country are also trying food prescriptions programs, which essentially subsidize the purchase of healthy foods.
Thank you, Tori. There's another question for you, and this question is about the VA homebound veterans. It's related to the Meals on Wheels program. Given that there's a chance for a budget cut in the future, do you have any innovative ideas for the future that can help serve these people who may lose their primary source for balanced meals?
So this is for me, and I also would encourage Dr. Becerra to answer also, because she had mentioned some work with veterans.
Absolutely, yes.
This is a very important question about policy changes. I think at this time it's important to advocate for the rights of people in the United States and to try to protect programs that help people to afford what they need in order to remain healthy.
Yes, that's absolutely correct. And one of the other things is with the Farm Bill, which provides the finances needed for SNAP, it's up for renewal in 2018. So it's absolutely a valid concern with the potential budget cuts maybe will not be renewed. What we've seen in a lot of cases like Meals on Wheels or other programs, not just among veterans but among others, is this is where philanthropic contributions come up. I think that's what we're noticing when it comes to reproductive health as well, where a lot of philanthropic contributions are happening when there's a budget cut. So with public health efforts going for those private donations early on, I think would be a very good preemptive measure to ensure that the finances are there. And having that advocacy that Dr. Mayer already mentioned, is that having the advocacy from the Farm Bill goes up for renewal in 2018 would be vital to make sure these resources actually exist.
Great, thank you. Also, Moni, if you can answer the next question, do you think that food insecurity may be underdiagnosed or under-identified? because people don't want to be seen as being like a bad parent.
Absolutely. I mean, this is where, we have that concept of social desirability where you don't want to report. This is the problem with any survey is when you're asking these questions, there's that bias that people may not report things because if you have a child who's ill and it's because you may perceive it's because of the lack of food, whether it's true or not, it's a different story. People are less likely to report. But the interesting part is anything like this, when it comes to a sensitive topic, tends to be underreported. But even with the underreporting, we're looking at really high rates in the United States. So imagine what it would be if everybody actually reported it correctly. So I think it is underreported, but even the underreporting is showing a huge burden. But it's a valid point. It's most likely to be underreported.
Another question, is there a link available to download the pamphlet on the traditional food guide? The traditional food guide.
Yes, it's actually it's a purchase because it helps support the guide, and I will post a link to connect in with the Alaska Native Tribal Health Consortium. It's also on Amazon, but you can get a great price if you want to use it for your programs or learn more about it.
And Gary, can you explain again what is ORAC?
ORAC value is a measurement of antioxidants. So when you think of berries right now, blueberries are great for us cardiovascular. There's been some great studies showing reduced cardiovascular disease for women who regularly consume blueberries. And so that's a store-bought blueberry study. And so our blueberries in Alaska and in the north, the harsher the environment, the more berries produce these antioxidants that actually are protective for us as well. So the ORAC value is a measurement of those antioxidants that show that wild blueberries exposed in a harsh environment actually produce more the antioxidants, so they're especially good for you.
And Gary, there's another question for you. Have studies been done taking non-Native people and having them eat a traditional Native American diet? What health changes occur? Are they similar to the Native Americans?
So that is very interesting, and I, to be honest, don't know of a study with our Native American or Alaska Native diets, but there is research. University of Pittsburgh did a study with African diets and African American diets where you switched them, and it was related to the changes to the microbiome. So traditional diet versus a processed diet. And fascinating, that's Dr. Stephen O'Keefe was the one who did that diet, because we've been also talking about studying and we're working with him on the changes to the microbiome, and it's related to colorectal cancer and also other diseases connected to the microbiome. So there are some limited studies out there, but not one with Alaska Native American Indians that I know of yet.
Okay. And Gary, I'm going to combine two questions into one. So what caused the 95% of food import in Alaska, and why isn't there a greater push towards growing and gathering and fishing and having more traditional foods available?
So there is a movement, and we're working very closely with the Alaska Food Policy Council, who hosts an annual conference on hunt, fish, gather. Right now, Chugach, which is one of our regions, their resource commission is hosting a conference on food security and how to hunt, fish, gather, grow your own food. There's a big push for it. In the 50s, we had about 50%, or a little bit more than 50% of our food produced locally in Alaska. And due to a variety of conditions, farming and lack of incentives to farming, buying more outside food, and so buying less local, for a variety of reasons, we've become very dependent, and there is a big push. And I'm hoping to see that number change over time, and I feel like there's been a concentrated effort to support more local farms, even in the western Alaska and the Yukon-Kuskokwim Delta. Tim Meyer has a big farm where they produce for the Bethel area and actually export greens. So Barrow has microgreens and a vertical harvest project that's across the state. We've got more going on. And in nationwide, it's definitely, I think of White Mountain Apache, I think of others who are doing some really great work around farming and having tribes be connected to growing their own food and growing their own culturally connected food, which, the food of our ancestors. So I would say that the trend is changing, but it's one where we've become very dependent, and we've got a lot of work to do.
This question is for anyone. How does food insecurity play a part in health equity?
I can address that a little bit, but please, anyone can feel free to join in. The thing with health equity is, again, when we talked about obesity, other chronic illnesses, all those contribute to it. So I think food insecurity could be easily considered a measure of health equity, because health equity is ensuring that everybody has similar outcomes, not necessarily beginning. So if food insecurity, when a population is food insecure versus another, that can be often considered a measure of the social determinants of health, which is part of health equity. So food insecure individuals long term are not living enough, long term are having more rates of obesity, type 2 diabetes, have poorer diet. All of those are overall is what's contributing the lack of health equity, or therefore health disparity with most populations.
And Tori, did you want to respond as well?
Yeah, I agree with what Moni said, and I would just also say that in order to achieve health equity, it's very important to address factors beyond the medical setting and medications and medical care, and food insecurity is an example of the way that socioeconomic situation impacts health, and how it's important to have a broader perspective when working to promote health equity.
Great. And Gary, did you have a response?
So I would say, especially as it relates to our indigenous populations, a lot of our indigenous populations have a history of being repressed, and from a health equity perspective, there's stories even into the 60s and 70s of, in Southeast Alaska, signs saying no Indians or dogs allowed. And so when you think of access to healthy foods and also the issues related to devaluation of your own food, like as native foods or traditional foods were less than. So from a health equity perspective, and we think of disparities in our populations, there's a history of historical trauma and repressed populations that, of course, create greater stress and create a whole host of issues. But it's definitely a health equity issue that is currently being addressed through local self-determination. It's a new era for Indian country, and again, I tend to focus on the bright spots. I think we're making gains, but we still have a ways to go, because very huge disparities in type 2 diabetes and food insecurity from indigenous people and other minority populations in the United States.
Great. Thank you, Gary. And there's another question. Do you have any resources available for how stress contributes to obesity? Moni, can you respond to that?
Yes, absolutely. Let me make sure I'm on. Yeah, I'm on. One of the things with stress is chronic stress. So this is not you're stressed out for a day because somebody has an exam. This is looking at 3 months or more stress, long-term chronic stress. What it does, it releases cortisol, which then impacts your hormones, impacts your metabolic syndrome. It increases your blood pressure, your cholesterol, your blood glucose level. It also leads to abdominal fat accumulation. So all of this leading to obesity, which then, and somebody actually noticed asked a question about asthma as well, and asthma and obesity are related because of the weight gain. So all of that cumulatively then leads to those chronic illnesses where obesity serves as a clinical risk factor for. So it's often the cortisol release early on, and then the adipose tissue buildup in the abdominal area often is strongly related to having that low food quality or unhealthy eating associated with food insecurity.
Thank you, Moni. And this is a question for anyone to respond to. If people need to go to food banks, how can we make sure that they get appropriate and adequate protein in their diet? Food banks don't usually give cheese or eggs.
So I think that certainly being aware of the protein content and the nutritional content of foods provided by food banks is an important part of recommending particular facilities to individuals who you're interacting with. And I know that a lot of food pantries around the country have been working on making sure that the foods they provide are not just adequate from a calorie perspective, but also healthy.
Okay, thank you. And we have time for one last question, and that is, how do we promote healthy eating habits in food deserts?
I just wanted to add like a quick resource that might be useful, and definitely, Gary, please follow up on that. One of the things that we've noticed where we live, because we're in San Bernardino, which is one of the worst food desert areas, we have a high Latino population, high immigrant population, high non-English speakers. So a lot of that has contributed to having that lower healthy eating behaviors. However, we found, and this kind of ties in with the protein question, is that a lot of times meat and eggs can be more expensive. However, beans and legumes are not. And a lot of beans and legumes tend to be high in protein. So that, what we've noticed in a small scale on our campus has worked with our population, is promoting those instead of more expensive resources for proteins and healthier options as a way to eat healthier. Even if we live in a food desert, legumes or beans are more readily available.
Great. Thank you, Moni. And Gary, did you have a response for that?
Yeah, and I would say that reframing food deserts and really working on developing your own local food systems, getting involved with your local food policy council to encourage folks to grow their own food. And sometimes it's a perceived food desert, like in Alaska and some other areas where there are local food systems that folks just don't know how to access or need regulatory or policies changed so that folks can be more connected to their food system. There's a national movement towards addressing food deserts in ways that empower people to be more connected and grow their own food. And I feel like that's an area that we all need to get behind and model and practice. And even in some of the more very difficult food deserts, you can have some very deep urban populations. You can do some really cool local food projects, and I think there's some really great best practices in doing so. Thank you.
Great. Thank you all for the questions, and also thank you to the presenters for your answers. We invite everyone to please visit our NDEP website. It's www.cdc.gov/diabetes/NDEP. And we also remind you to check out the many resources that we have, which can help you in your diabetes education prevention as well as your control programs and classes. Please feel free to contact either me directly, Michelle Owens Gary, at mowens1@cdc.gov, or you can also contact the National Diabetes Education Program at 1-800-CDC-INFO, CDC Info. Again, we'd like to thank Tori, Moni, and Gary for sharing your expertise and your words of wisdom. Thank you again for joining us. This concludes the webinar.